Start.
Yes. Can I see my PPT? Yeah, okay, fine. So, good afternoon, everyone. Myself, Dr. Kanchan Durugkar. I am consultant at Oasis Fertility Pune. Uh, in this whole month of June, we are discussing about the male infertility. What are the different causes of male infertility? How to treat various causes of male infertility. And today, in this last session of this month, we are going to discuss about what are the advanced treatment that are there available for male infertility. So we will be discussing about first the causes of male infertility. So what are the causes of male infertility? So there are different causes, and 30%, 30 to 40% of the infertility can be because of male factor of all the patients with infertility. So what are the different causes? That there can be sexual dysfunction, there can be some count related problems like azoospermia, oligozoospermia. Then there can be some problem related to morphology like teratozoospermia, a motility related problem like asthenospermia. So these are the different causes which can be the reason for male infertility. So how to diagnose a male infertility? So basically, the semeiosis is the first and foremost test that has to be done. So proper semeiosis needs to be done for the patients to diagnose what is the reason for the male infertility. So in that semeiosis, we need to see for the morphology, count, motility of the sperms. So this is how it is done. Then procedures can be different types like um, IUI and ICMR. But in today's topic, we are going to discuss about the advanced treatment of male infertility. So causes of male infertility can be oligozoospermia, azoospermia, and other problems also. So what are the causes of this azoospermia? So azoospermia can be because of, again, it can be pre-testicular, testicular, post-testicular. Now treatment of azoospermia depends upon what is the reason for azoospermia. So if it is pre-testicular, what are the treatment options? Then if it is post-testicular, then what are the treatment options? And if it is testicular, what are the treatment options? So that we are going to discuss now. uh, how to first investigate the patient with azoospermia? So first and foremost, the basic investigations, hormone profile that we do, and the genetic testing of the male partner we do. So what are these hormone profiles that we do, so that we can evaluate the patient whether the azoospermia that the patient is having, if it is pre-testicular, testicular, or post-testicular. So we do the hormone profile in the form of prolactin level, thyroid level, FSH hormone, and testosterone hormone. Also, we go for USG scrotum of the patient. Also, we do the karyotyping. Also, we can do the Y chromosome microdeletion testing of the patient. Now, after testing this, we can know the hormone status of the patients. So, if the hormone status is like FSH hormone is raised and FSH hormone is on the higher side, so it is most probably a testicular cause. That is, hormones are the hormone FSH is basically a hormone secreted by brain. So the FSH hormone is getting secreted properly, but it is acting on testis, but the testis is not able to produce the sperm. So that's why the FSH level is showing raised value. So that can be a reason for testicular azoospermia. Sometimes there's FSH and LH level can be low. That is, we call as hypogonadotropic hypogonadism. That is the uh, pre-testicular azoospermia. Pre-testicular is rare. Only 4 to 6% of the patient may have a pre-testicular azoospermia. In these patients, genetic testing is very important, because to know the genetic cause anything related with this hypogonadotropic hypogonadism. So in these patients, the hormones level will be very low. So the brain secreting this hormone FSH and LH is very low. So that hormones are not acting on the testicular tissue. If this is not acting on the testicular tissue, the testicular tissue spermatogenesis is not happening, and then again the sperm production is not there. So this is the very few patients may have, few percentage of patients may have this problem. Then testicular, that we have already discussed, that in this the FSH level will be more, but the testis has some problem. There is some testicular damage, some infection which is not allowing the testicular spermatogenesis, and this it is a cause of testicular uh, azoospermia. Then post-testicular obstructive azoospermia. It is a most common. 60% of the patient that we get in our body are obstructive azoospermia patient. Now, how to evaluate these patients? In this patient, generally the FSH level will be normal, testosterone level will be normal, and other hormone level will also be normal. Now, why there is a problem? Sperm production is normal in this patient. Production is happening in the testis. The signals in the form of hormones is also there from brain. Then testis is also producing testosterone, and sperm production is also there. But there is some obstruction at the level of vas deferens or at the level of epididymis, which is not allowing the sperm to come into the ejaculate. So that's why there will be a azoospermia. So most of the patients, 60% of the patient have this as a reason of azoospermia. Now, and these patients generally have good prognosis of sperm retrieval. So these patients needs to have other test also we can do, that is CFTR gene mutation test. In this we see for the genetic condition where the vas difference will not be palpable and CFTR gene mutation can be there. So in these patients, the sperm retrieval technique will be TISA. And so obstructive azoospermia patients, we go for TISA. Now, these are the various reasons of azoospermia that we have studied. Now, and in genetic testing also we need to see for 47x, for 46XY chromosome is there, or is there any problem in the genetic testing? Is there any translocation? Is there any inversion at any chromosome? That we need to look for, and accordingly we can plan of whether we can go directly for TISA and then transfer, or we have to do the PGT, that is the prenatal genetic testing of the embryo, and then we need to go for transfer. So these are all things we plan according to the basic test that we do for the patients coming to us with either oligozoospermia, cryptozoospermia, or azoospermia. Now, coming to the various treatment modalities that we go for. So generally routine IVF was done when the sperm count, a male factor is not there, but generally we go in the recent advances we go for ICSI. ICSI is a process in which even a patients with less than 5 million sperm count can be given pregnancy with their own sperm, because a single sperm is injected into a single egg. So that will give the ICSI technology, that is called intracytoplasmic sperm insemination. So basically, the ICSI technology was invented for severe oligostenospermia, and in these patients, in the patient with severe oligosteno, or the patients with where the testicular sperms are retrieved, testicular sperms are there, like TISA retrieved or micro TISA retrieved sperm. In these patients, ICSI can be done, and the outcome can be improved. So this is how it looks under microscope when the ICSI is done. So ICSI is one of the recent technology that is used for the patients with azoospermia or oligozoospermia. So So azoospermia. So this is how the azoospermia looks when there will be no sperms at all. So what can be done in this patient? So according to the various types of the azoospermia that we have discussed, that whether it is pre-testicular, testicular, or post-testicular, we advise the patient that either we can go for TISA, or we need to do the TESE, that is micro TESE, that is testicular sperm extraction. So what is TISA? TISA is testicular sperm aspiration. So what is aspiration? Basically, in the picture we can see there is a needle that goes in, and only a needle prick is there, and then with the negative suction, the sperms are aspirated. So here there is no incision over the testis. So there is no incision over the scrotum or testis, just a needle prick is there. So this is basically a short procedure. It is done under anesthesia. In Oasis we do it under the short GA, short general anesthesia that we call it. And this procedure takes half an hour, and after that the patient, it is again a daycare procedure that is carried out, and the patient can go home same day. Okay, it is a daycare procedure carried under anesthesia, and here only a needle prick is there. Patient is not given any incision, so there will be no stitches. So this is TISA. So TISA is very effective in the cases of obstructive azoospermia, and sometimes in the patients with testicular causes also. In some patients we can get sperm with TISA. So if at all the patient is having more problems like testicular problem of azoospermia, like there is a problem in testicular formation of sperms. So in these patients microtese is required. So what are the indications for microtese? So it can be the hypogonadotropy, hypogonadism patients also. Again, there the prognosis is guarded, and in the patient with testicular causes in the sense, in those patients in which the hormone level are there, but at the level of testis there is some problem in spermatogenesis. So in these patients testicular sperm extraction is done. So basically it should be done under microscope, that is called microtese, that is testicular sperm extraction. So here the tissue, the basically the testis is exposed after giving the incision over the scrotum, and after the incision over the testis, the tubules are extracted under microscope, and they are seen for the sperms. So again, this microtesse technique has also found to be effective in the patients where TISA has not it was ineffective to retrieve sperms. So again, it is one of the recent advanced microtesse, that is a testicular sperm extraction, where we actually under microscope see for the seminiferous tubules, and we extract them under microscope, and then we under microscope in the IVF lab, we see for whether we can retrieve the sperm from the tubules or the spermatic tissue that we have retrieved in this procedure. But again, this procedure is a bit more uh, exploratory, we can say, because here there is an incision, like incision will be again small incision is there of 2 centimeter, and the patient will post-operatively patient will have stitches, and pain is bit more in the patient with microtesse. But again, this can give the successful sperm retrieval in the patient whom the TISA has failed. So this is the procedure of microtesse. This is how it is seen under the this is the operating microscope, where under which the testicular tissue is visualized, and this is how the seminiferous tubules are extracted, and they are checked under microscope in the IVF lab, where we can see for the we have to explore for the sperm, and these sperms, testicular extracted sperms, are used for ICSI. So this is a again a recent advance that we see in the patients with uh, te- azoospermia. Then these are the two sperm retrieval technique that we have seen. Now PGTA is again a technique which can be used, and PGTSR basically in the patients with again, which I have discussed, in which the karyotyping is showing any problem. That is, if there is any translocation like Robertsonian translocation or inversion is there in the karyotyping of a male partner, then in these patients genetic testing can be done, that is called pre-implantation genetic testing. In this we can do the embryo biopsy, and the biopsied cells, 7 to 8 cells are uh, 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 aspirated, and these are sent for the genetic testing, and we can see for the euploid embryos, and from the embryos that are been subjected to embryo biopsy, and from this the euploid embryo can be subjected for embryo transfer. And again, this is a recent advance which has come for the patients with oligo or azoospermia having genetic problems. So this is the, and here PGT-SR or PGT-M for monogenic disorder can be implemented to overcome the genetic problem which is causing the male partner to have oligo or azoospermia. So uh, PGT-SR or PGT-M. PGT is for PGT-A is basically for recurrent implantation failure or recurrent pregnancy loss, but PGT-M and PGT-SR for the any and genetic problem that is causing male infertility. Then coming to the other sperm selection techniques, basically these techniques are the recent advances that are used. These are the sperm selection technique, basic sperm selection technique. These are basically used for the patients with oligozoospermia, or the patients with raised DFI, or the patients with motility problem, asthenospermia, and in whom there was a previous fertilization failure. In these patients, these sperm selection techniques can be used. Now, what are these different sperm selection techniques? These are microfluidics and MAX. MAX is the magnetic assisted cell sorting. So, what is microfluidics? We will discuss in brief, so that we need to know about it. So, it is basically a sperm selection technique, as we can see in the slide, that there are 4 wells. In this, in one well, the sample is instilled, and in the 2 wells, media is instilled, and in the 4th well, we get the motile sperm, which can travel through this media, and from the 4th well, the sperm samples are selected, and these selected sperm samples are used for the ICSI technique. So these are the selected sperm. So this is the sperm selection technique which can be used in the patients with oligozoospermia, oligoteratozoospermia, in which because of this lamellar flow, the motile and the sperm with better morphology will be carried to the through laminar flow to the chamber, and these motile sperms will be selected for the ICSI technique. So this is the sperm selection technique. It is called microfluidics. Yes, and it is very helpful to give good quality embryos in the patients where there was previous fertilization failure or severe oligoasthenospermia or raised TFI. In this patient, this technique has found to be effective and proven to be giving good outcome. Now, the other technique, other micro TISA I already discussed. Yes. So MAX. So MAX is magnetic assisted cell sorting. So in this, the basically, as we can see in the slide, so there is a mm, ma- basically it is a some to make more easy to understand, this is done. But in the chamber we take the sperm sample, and the magnetic field is basically applied, so that the damaged sperms, which are DNA damaged sperms, they can get attracted towards the magnetic field, and the motile sperm, which are having we will say healthy sperms, so they will get selected. They will with the flow, and these selected sperm can be used for the ICSI technique. These sperms which are selected through max, this can be used for ICSI technique. So in this max technology is again used for the patients in whom the motility is seriously affected, in who are having severe asthenospermia and teratospermia also, and again raised DFI also, also in the patients with recurrent pregnancy loss. So this technique is basically useful in the patients with decreased motility. So again, it is one of the uh, advanced sperm selection technique. So these are the different methods. These are the recent advances. Again, there is a IMSI technique, where the morphologically selected sperm is taken. This morphological selection is done under an advanced microscope, and this morphologically selected sperm is used for X-ray. It's called IMSI. Then other methods that I have discussed about the genetical testing, PGT-SR, PGT-M. Again, these are the different selection, embryo selection technique, basically, which can be used in the patients with abnormal karyotyping. Again, these are the different sperm selection techniques and sperm extraction technique that we have discussed as an advanced treatment in the patients with male infertility. Sometimes these patients may need to be given like a patient with the hypogonadotropic hypogonadisms patient may need to be given a long-term treatment in the form of gonadotropins or SCG for say 1.5 years to 2 years also. And then in these patients, sperm retrieval technique has to be up, patient has to be subjected for this sperm retrieval technique. So these patients, patient to patient, this management differs, whether the patient is having oligozoospermia, whether the patient is having azoospermia, and which type of azoospermia the patient is having. According to that, the treatment of the patient varies. So but still sometime there may be a failure in the sperm extraction. There may be no sperm in spite of doing all these recent measures of sperm extraction. In this patient, we may need to use donor sperm samples for the patients when the patient is female is going through a IVF cycle. So if the sperm retrieval has failed in those patients, we need to use a donor sperm also. So these are the different uh, problems, and how to come across these problems in the patients with male infertility. So that's all from my side. If at all there are any queries regarding these topic or any other topic that we have discussed in this month regarding male infertility, you can comment us on the in the comment box section. You can ask us in the comment box section, or you can have a physical consultation with us. Our centers are at Oasis Fertility, Bakad, Pune, and Kharadi Center. So that's all from my side. Thank you very much for your patience listening. Yes. So can zero sperm count be cured? So, can zero sperm count can be cured? Yes, zero sperm count is basically azoospermia, and our previous Facebook live session was on the same. That is the pregnancy possible with zero sperm count? Yes, it is possible with sperm count, but in these patient, we need to take the help of sperm retrieval technique that I have discussed in this Facebook live. The sperm retrieval technique can be in the form of TISA or microtese, that is testicular sperm aspiration, or microsurgical testicular sperm extraction. Which treatment is best for azoospermia? Uh, as I have discussed in this Facebook live session, that uh, azoospermia can be due to different causes. It can be pre-testicular, it can be testicular, it can be post-testicular. Most commonly we come across is the post-testicular. It is the obstructive type of azoospermia. 60% of the patient will have obstructive type of azoospermia. So in these patients, it can be treated best by TISA. So TISA sperms we can use for ICSI, and yes, the pregnancy can be given to the patient with their own sperm, with their own gamete. Does IVF work in azoospermia? Yes, though azoospermia for many patients it may be a very distressing thing. Yes, it is a distressing thing for the patient who are facing it. But yes, IVF is a bliss for them. It can work for them, and they can have baby with their own gamete, with their own sperm, and different recent advances that we use in the patients with azoospermia definitely is a bliss for them. Which exercise increases sperms? Uh, Basically, over exertion, over gymming, basically may be a cause of oligoasthenozoospermia. Basically, over gymming can decrease sperm count. What I will say, over gymming. Uh, regular, if the half an hour exercises is there, then it will basically increase good hormones, and they can uh, increase the morphology, normal morphology and motility. But if there is excessive gymming, then that can cause basically not azu, but oligozoospermia in the male partner. Again, the same question is coming up, that can a man with a zoosperm have a baby? Yes, yes, that I have been telling in, and in the whole month in our Facebook live we have been talking about that. Yes, with zero sperm count also pregnancy is possible with the advent of newer technologies that we use, with the advent of the sperm retrieval technique that we use, that we have talked about in this Facebook live session. uh, we can directly, with the needle, with the help of needle, simple needle aspiration, when the test, when the sperms are there in the testes, but they are obstructed because some or the other cause is there, that the sperms are not coming out. So in these patients, just with the needle aspiration we can aspirate those sperm. We see under the microscope that we get the good quality sperm in this, and we do the ICSI, that is the intracytoplasmic sperm insemination in the egg. For that, yes, for this we need to go, female also has to go through IVF, and husband also has to go through TISA, that is a sperm retrieval technique. And yes, the embryos can be formed, and with the embryo transfer of this formed good quality embryos that are formed, the embryo transfer, frozen embryo transfer, we can get the pregnancy. I think that is all from the question answer side. uh, yeah, so we need to end this show. Thank you very much. Thank you, everyone. Have a good day.